Lesson plan is on loss, grief, and dying. According to Ken Sutton, he states that the grief after a death is sharp and strong. It pops up at unexpected moments, even years later. We all experience loss and grief at some point in our lives. Ultimately, the final, though, is being death. How everybody handles this differently, and we should be very respectful of others' feelings of loss and illness and the end of life situations that they need to encounter. 3 theorists that you need to understand and know and be aware of for the foundations of grief are Engel, Rando, and Kubler-Ross. Engel, he believed that uncomplicated grief has a clear onset and a predictable course. It's modified mainly by the abruptness or significance of the loss and the preparedness of the person who is grieving. Uncomplicated grief is universal and does not require treatment, according to Engel. According to Rando, Rando came up with the 6 R's of grief. Recognizing, that's a loss of awareness. Reacting to the separation, that's our feelings, our emotions. Recollecting the memories of the deceased, that's remembering or reliving them. Relinquishing the old attachment, there's new ways of living without the deceased. Readjusting to the new environment, that's our new coping skills. And then reinvesting self, that's energy that's once turned inward on grief begins to be focused more outward. So Randall did the 6 R's of grief. And then the one you'll hear a lot of also is Elizabeth Kubler-Ross. She had the 5 stages of grief, and this is called the DABDA, the DABDA. D is for denial, A is for anger, B is for bargaining, D is for depression, and A is for acceptance. Individuals may not experience every stage of the grief or go in a linear order. In other words, going from denial to anger to bargaining. You can go through several at a time. You can intertwine. I could be depressed one day, the next be anger, but down the road I can go back to being depressed again. And that. So a person can experience 2 or more stages simultaneously. So you need to know the 3 theorists that are associated with grief. Different types of grief that a person can go through. Always make sure, again, that you know whether they're grieving, mourning, going through the loss, that you understand and show respect again to how a person feels. Again, going along with culture, some cultures, they dictate how long a person can mourn and how a person should act. So just make sure that accordingly to each individual, we treat them with respect. Uncomplicated grief, or what we call normal grief, that's a natural response to a loss. It's where the bereaved person can experience feelings, behaviors, cognitions that are expected in light of his or her cultural, social status, and relationship to the lost person or object. These emotions, they can be very intense, but they gradually will start to diminish over time. Now, this can be several months to several years. Again, everybody is different on how they react to grief. Some emotions, they're always going to be present, but the intensity should change. It should get lessened as time goes on. Complicated grief, that is distinguished from complicated grief by the length of time and intensity of emotion. The person's responses are maladaptive, dysfunctional, they're very unusually prolonged, and they can be very overwhelming. Complicated grief results when the grieving process has been impeded for some reason. That could be something as such that a person is stuck in the grief process. There are 3 sections to complicated grief. There's chronic. That begins as normal grief, but can continue long term. It has little resolution of feelings and the inability to rejoin normal life. It just keeps going on and on and on, and it's chronic. Mask, now that occurs when the person is grieving, but expresses the grief through other types of behavior. It looks similar to something else. For example, a person's going to drink before bed, so it looks like they're abusing alcohol when they're masking that grief. They're still grieving. Delayed grief, that is grief that is put off until a later time. An example, I'll think about it later. Right now, I'm just busy trying to keep a roof over our heads and care for my children. They're not thinking of the grieving process at the moment. It may happen later. These are all three of these are forms of complicated grief. Disenfranchised grief, now that is experienced in connection with a loss that is not socially supported or acknowledged by the usual rites or ceremonies. It can be experienced by, let's say, a man whose wife has had a miscarriage. A bereaved partner in a homosexual relationship is not recognized by families. In each of these instances, the bereaved person, they lack the communal support that is helpful to them in their grieving process. Anticipatory grief, that is experienced before a loss occurs. The potential is a negative outcome is that the survivor may detach from a dying person too early in the dying process. This leaves that person who's dying without any emotional support during that phase. This does not always happen, though, just so you're aware. But these are the different types of grief that we may see as nurses. Death defined. It's defined by several factors. One is the higher brain death. This is where the brain stem can still be functioning. So both your respiratory and your cardiac activity, they may still continue even though the person does not make any purposeful responses to any external stimuli such as rubbing the chest. Any cephalic reflexes are absent, and the electrosonogram shows no activity. That's your higher brain death. According to the Uniform Law Commission, they redefine death broadly as the irreversible cessation of all functioning of the brain. This includes the brainstem. That is as determined by reasonable medical standards. This definition did not provide clear guidance to states, so there are many that don't even follow this one at all. The most common one that we do follow is according to the Uniform Determination of Death Act. This was adopted in 1981. And it helps to further clarify and expand the previous definition to include irreversible cessation of circulation and respiratory functions. That is based on acceptable medical standards. Healthcare providers, they use several methods to assess for the functioning of the brainstem because the bodily function declares death, and that has to be by the brainstem function, such as a person's pupils are fixed, non-responsive to a light, so if flash a pen light in their eyes. They have no corneal reflex. If you touch their eyes, they don't move or anything. And then they have the absence of the vestibular ocular reflex. Again, rubbing their chest, anything moving, not. So the one that we do follow the most is the Uniform Determination of Death Act, which declares death by the brainstem function. Coma and a persistent vegetative state. Coma, that is a prolonged, deep state of unconsciousness that can last days or even years. The patient cannot be aroused, and they may or may not have decreased brainstem reflexes. I always say if someone's in a coma, even if all the way till they're dying, I always say until they're out of my building and out of my sight, I will talk to them at all times. Hearing is the very last thing to go. So if a person's in a coma and they would wake up, be careful what you say in front of a patient. They can hear, whether you believe it or not, so just make sure you know you're appropriate when you're working with those clients. The other one is persistent vegetative state. This is where they have the loss of a higher cerebral function. The person does not purposefully respond to stimuli. They're unaware of the environment and they have no cognition or affective mental functions. They're basically there. This is the definitions of coma and a persistent vegetative state. Care that you will see. You have either palliative care or hospice care. Palliative care, that's holistic comfort care. That's where it's aggressively planned. Holistic comfort care. General issues for most end-of-life care patients, they can include that we support families and caregivers, ensure continuity of care, respect for the person, ensure informed decision making. They always have the opportunity, as long as they're coherent, to make choices, change plans. They're still in control of how things go. Attend to emotional and spiritual concerns. When someone is grieving the loss of a family member, it's things that can help support, as well as though also can create difficulties or hinder a person's ability, is what type or how strong their spiritual beliefs are. That can be very hard. So that's why it's good to, attend to their emotional and spiritual concerns. We want to support functions and survival duration. And then manage any type of symptoms they have, such as pain, dyspnea, difficulty breathing, or any depression. Those are all a form of palliative care. They still can take some medicines with palliative care. With hospice treatment, that's based on two key premises. The quality of life isn't as important as the length of life. Those who are terminally ill should also be allowed to face death with dignity and be surrounded by comfort of their homes and families whenever possible. A lot of times hospice providers, they're considered helping family members as an essential part of their role. With hospice, in order for a person to even be in hospice, they have to have a doctor order or write that they have less than 6 months to live. With hospice care, they stop all treatments. They do more of comfort as far as if someone's in pain, someone's restless, they'll attend to those needs. If they need something as simple as administering pain meds to keep them quiet, we'll do that. We also want to make sure that if they need maybe eye drops for their eyes, we give them eye drops. That's not stopping. That's helping them with comfort when they're at the end of their life. So know what palliative care is and know what hospice care is. Palliative care, that can go on for years, where hospice care, again, it needs to be 6 months or less and ordered by a healthcare provider. And ethical considerations to be aware of are listed. One is advanced directives. Those are a group of instructions, whether that is written or oral, that states a person's wishes regarding his or her health care if he or she were incapacitated or unable to make that decision. An ordinary power of attorney does not give another person the right to make healthcare decisions for the client. Only a durable power of attorney for healthcare decisions can do that. With advanced directives also, the client is always allowed to change their decision about treatment at any time, as long as they're alert and coherent and are able to understand those decision-making activities. Do not resuscitate, or a DNR, or an A&D, which is allowed natural death. This is in order to not attempt any resuscitation of the patient in the event of a cardiac or respiratory failure. The ANA, or the American Nurses Association, they recommend to allow natural death, or the AND. Assisted suicide, that means making available that which is needed for the patient to end his or her own life. That can either be by some type of pharmaceutical agent or a weapon. The patient is physically capable of ending his or her own life, has expressed the intention to do so, and has turned to the healthcare provider merely to supply the means. Just so that you're aware, the ANA, according to 2013, they prohibit nurses' participation in assisted suicide and euthanasia because those acts are in direct violation of the nurses' ethical traditions and goals of the profession, and it's covenant with compassionate care. So just know that we as nurses, we have an obligation to provide humane, comprehensive, and compassionate care that respects the rights of clients but upholds the standards of the profession in the presence of chronic, debilitating illness and at end of life. So even if you live in a state that has assisted suicide, as a nurse, it's very frowned upon. Euthanasia. Euthanasia refers to the deliberate ending of a life of someone suffering from a terminal or incurable illness. Active euthanasia, that occurs as a result of a direct action, such as giving an overdose of a medication. Or passive euthanasia, that occurs as a result of a lack of action, such as we're withholding medications or food that's necessary to sustain life. Euthanasia, one of those could be it's such as someone's going to the prison systems and they've been convicted to be put to death. That's when you have to think of your own ethical considerations on, can you be the nurse to give that medication to stop someone's breathing, to actually make them be declared dead. It's just something to think about if you can or can't do it. And it can't be, well, I can do it for this person. Oh, I can't do it for that person. Make sure that you know what you can and can't do. And then autopsy. That is a medical examination of the body. That determines what is the root cause of death. That involves removal of organs or extraction of any tissue samples. Autopsies, are very good to determine relevant data as far as what type of disease process was going on. A person who is declared with Alzheimer's disease, they technically cannot have the diagnosis of Alzheimer's disease until they do an autopsy of that brain and seeing what the white matter in the brain it has. And that. Autopsies also, they require signed permission from the next of kin, except in cases where there is a suspicion or an unwitnessed death, then it's required by law. And then organ donations. Organ donations is where a person can state what they want done after they have passed. What do they want done with their body? Do they want to donate certain parts of their body to science, to another person, medical research? Organ donations, a lot of times on your driver's license now, they will say, are you an organ donation, yes or no? So organ donation, again, that is individualized. Everybody makes their own decisions on what they want and what they don't want to donate. Always remember when you're talking about legal and ethical considerations, again, just be respectful of clients' wishes, listen. Sometimes we don't have to say anything. Never give your opinions. Always kind of wait it out and let them guide in what's being done. But do understand legal and ethical considerations that are listed. Just a question to think about, and that you have a 55-year-old patient that was just informed that she has metastatic pancreatic cancer and has 4 months to live. After the provider leaves, she says to you, I don't want my family to know, but they have to know. Please don't tell them. Please tell me what to do. Help me. What is your best response? So a lot of times it could be, I know this is difficult for you. Take time to think about it. You should get a second opinion before you alarm your family. Let me hold your hand to make you feel better. Or tell me how you are feeling right now. The ability to engage in safe and effective nursing care, that requires an understanding of the process and therapeutic interventions to handle loss, grief, and dying. what you need to do is just remember the best one of those four is have them tell you how they're feeling right now. Don't give your opinion on that. Provide information to the person so they can make an informed decision without leaving the client's bedside. Again, don't offer opinion or minimize concerns. Don't make statements such as don't worry. You're kind of belittling them. Also, do not offer false reassurance that clients will likely find until returning to a certain situation. So always give the choice and put the choice back on the person. And that our due diligence, though, is to the person only. That we're taking care of, so be mindful of that. But think about, safe, effective nursing care when you're taking care of a client. What do you do when you lose a patient or a client yourself as a nurse? It is normal for you to feel grief when our clients die. You also have to always remember you need to take care of yourself. You need to think about this, and some of the things to think about is it okay to cry in front of families? Is it okay to show emotions? Do I need to be stone-faced? These are things you need to think of, and they're individual. Some people, yes, absolutely can cry in front of someone else. Others absolutely cannot. A lot depends on culture also. But when we take care of clients, we kind of become their family members as well in a professional way. And the loss can be very traumatic to us. And it also depends on what events led up to the loss of that client. Was it traumatic? And if it was traumatic, make sure you do a debriefing about the situation. What went well? What could have went better? How am I feeling? Get those feelings out. It's okay to do that. Just always remember, you have to take care of yourself as well. However, we have a job to do too, to making sure that we have the body go to the appropriate nursing home. Excuse me, not nursing home, funeral home. Are the wishes being followed through that the client wanted? Are we notifying the appropriate next of kin? A lot of facilities have a checklist on what you need to do at the time that someone does pass so that you're following along. Also be aware of any spiritual or cultural beliefs, to honor those as well. But just think about loss of a patient. How do you feel? Is it normal to feel grief? Just think about it. To think about Socratic reasoning. Bob and Kim were walking with their 5-year-old twins when a driver lost control of his car and hit them. Both girls were rushed to the hospital, where one was pronounced dead on arrival. The other twin suffered several broken bones and was listed in stable condition. She keeps asking for her sister. Things to think about. What factors should be considered in this scenario? How would you provide care to this family? The concepts of loss and grief, developmental stage, and circumstances of the death, those are some factors that you have to consider. And that, thinking about it, you need to apply the theoretical knowledge to practice. You need to understand concepts of loss and grief. This scenario, it actually involves an actual loss, unexpected removal of a person. Again, grief is emotional. It can be either physical, psychological, or spiritual, and it's a response to the loss and is a normal occurrence. An unexpected violent or accidental death, that can transform normal grieving into a very more intense form, such as complicated grief with depression, suicidal ideations. It can also be disabling physical symptoms. In this case, the developmental stage of the child, that also needs to be considered. These are 5-year-olds. At age 5, the daughter may understand that death is permanent, but will require a very healthy post-trauma environment to recover and heal. She may want to remember her sister and may want objects or attachments and have questions as to why she died, and or may experience physical and psychological symptoms that will require their attention and support. At the time, just know parents are also grieving. They also need both support and understanding the needs of the surviving child and that. So it's just knowing, sometimes listening and that. Make sure you give an effective act of caring, such as maybe providing a hug, holding a hand as you allow them to talk, express feelings, fears. Sometimes we don't have to say anything. We just have to be present, but know that we're listening to them. And that means, that you're paying attention to them. You're not looking around at other places. But just think, how would you provide care to this family? This ends the lesson plan on grief. What questions do you have? Please bring them to class, or you can send an email.